So I'm delighted all of you are in the room today, ready with clickers in hand to participate in this very interactive workshop on new directions in STI clinical management, highlights from the 2010 CDC STD treatment guidelines. So if you're willing to go with me on this ride today, though, I should probably introduce myself, because although I know some of you in the audience, I'm not sure all of you know exactly who I am or what I do. So my roots are, I'm actually a pediatrician and a pediatric infectious disease specialist, and I do still practice at Boston University Medical Center on Thursday afternoons doing same-day sick with adolescents. Actually, that's my primary focus at this point in my career. The other thing is I don't think about STDs all the time, and I still am a PDID doc over at BU Medical Center, so some of you will see my name on charts there related to that as well. But the one major portion of my life now is that I have a position at the Massachusetts Department of Public Health where I'm the medical director for the Division of STD Prevention, and that actually comes with it the ownership of one of 8 wonderful clinical training grants that focus particularly on postgraduate medical education. And years ago, when Susan Gray and I were but residents and fellows together, we dreamed of doing things like this, but we would have to do it on pennies. And now here we are, fast forward 5-10 years later, and we can actually do these things as joint operations, partly off of CDC funding for making sure that clinicians stay up to date in the area of STD diagnosis, management, and treatment, and sexual health as well. So we cover the New England region, and if any of you are eager to learn more, today is but a teaser of what you could learn. You could spend a lot more time, valuable time, in a vaginitis workshop relearning how to do wet mounts. Oh yeah. Okay, so before we begin, today's goals are to gain some insight into hot topics in the STD clinical management world, highlight areas of the 2010 STD treatment guidelines that should be read carefully for final recommendations, and we're going to do this interactively. So here's a fun thing for those of you who are not so much in the know about how these guidelines come about. Well, of course, they come about from a committee, right? And a committee, once somebody told me, it must be like a Ben Franklin quote or something, all stomachs, no heads. That ultimately is very hard to decide things on committee. And that sometimes undoubtedly explains some of the more schizophrenic messages in pieces of the document. If you're ever wondering why one place seems to say something and the other place says something else, well, experts don't always agree. However, the treatment guidelines development process does wind up being evidence-based on some principal outcomes of STD therapy that are not always the outcomes you and I as clinicians practicing in clinic focus on. They do focus on microbiological eradication. They do focus on making sure the patient feels better from the signs and symptoms point of view. They do focus on prevention of sequelae, but they also focus on prevention of transmission. There is a very clear public health message that comes across. These are the CDC STD treatment guidelines, and I'm going to highlight some of the reasons that might be really interesting for us as clinicians to understand why it's so different, and why in some settings, kind of be aware of the fact that we are over-prescribing antibiotics in some ways, contrary to what we do with our messages with our kids who have viruses, and we don't want to over-prescribe antibiotics. These are sometimes somewhat different messages. Okay. One of the interesting things about the recommended treatment regimens are that they're distinctly preferred over alternative regimens. This may not have been so clear before 2010, but at this point the CDC is sort of saying, listen, you better have a really good reason to pick something on that alternative list, like a terrible allergy, directly to the drug on the recommended list, because the recommended drugs are actually on the recommended list because percentage points, maybe not always statistically significant, may be better at microbiologic eradication, or something else made it slightly better based on evidence, based on research, and therefore it hit the recommended list, not the alternative list. Here's a fun little detail. They're alphabetized unless there is priority of choice. So the fact that ceftriaxone is higher on the list than cefixime for gonococcal treatment is a subtle thing telling clinicians, if you read the finer print in the first 10 pages of the 120-page document, which I'm sure you do all the time, it says actually they're alphabetized unless there is a priority of choice. And ceftriaxone is actually really recommended over and above cefixime. A not so fun thing to admit. You know how long it takes to get these things out the door of the CDC? They were reviewed in April of 2009. They didn't get published in 2010 until 2010, December 17th. And it is because Tom Friedan, literally the guy at the head of CDC, has to sign off on it. A bunch of agencies have to sign off on this thing. Okay, and the MMWR queue is probably as long as a loop around the equator at this point. So it is a very inefficient process, which tells you almost immediately, as soon as the darn thing is published, it's already probably slightly out of date. But you do with what you can. CDC is getting savvier about getting the word out, not only through this network of STD HIV prevention training centers, of which there are 8 clinical ones across the land, but they have all sorts of magical things on their website, like pocket guides and teaching slides and charts, and there's an app for that. There is now an e-book on the CDC STD treatment guidelines. I downloaded it to my iPad, which I only got a few weeks ago. You know what, the thing is just like recycling of like the paper version. I don't know that it's any better, but it's kind of fun. You can get it on your iPad. Prevention and screening issues. There are some new messages in 2010. The 2010 new messages are, first of all, there's a whole new section, this is the bottom of the slide, screening in correctional facilities. Never before. Data from epidemiology in correctional facilities about how many percentage points higher is the prevalence of trichomonas, is the prevalence of chlamydia, is the prevalence of gonorrhea, how jails wind up being, and correctional facilities wind up being nexuses of communication of STIs and potential transmission back to the community. And cutting down on jail transmission, arguably with a captive population, might cut down on community translation. So for those of you who might work with DYS or children in custody or even adolescents, young adults post-captivity, et cetera, these are some of the things that you might think about. There's a whole new section. In terms of the older sections, in pregnant women, asymptomatic BV or trick screening or HSV2 serologic screening, still not recommended. Adolescents, they expanded the explanation of benefits, arguably for an adolescent savvy audience. The stuff that they talk about in the CDC STD treatment guidelines is probably too basic, to be honest. It's much better to go to a talk such as Martha Perry's talk that's coming up. For men who have sex with men, it has become very clear that the nucleic acid amplification tests, and I'll tell you how to get these, for the rectum and the pharynx are recommended for screening. And for women who have sex with women, this offering of the HPV vaccine, this idea that BV is common but screening is still not recommended, are some of the newer messages within the 2010 STD treatment guidelines, which tells you right now that the CDC STD treatment guidelines are not all about treatment. There's a whole section on prevention and screening. There's a whole section under each disease, once you've diagnosed the patient with it, some counseling messages specific to that disease, counseling messages specific to partner management related to that disease, how many days out you need to go to think back about the patient's previous partnerships, to know who should be treated with expedited partner therapy. All sorts of details like that are actually in this document because they are very concerned about the public health aspects and prevention of disease. Okay, without further ado, let's dive into one of the biggest changes within the 2010 STD treatment guidelines. We have a 20-year-old guy who presents with complaints of burning with urination and urethral discharge for 1 day. 3 female sex partners during the past year, didn't use condoms with any of these partners. Previously HIV and STD negative, but last checkup was over a year ago. On exam, this is not straightforward case. This is pretty straightforward. Pus at the urethral meatus. No epididymitis, no inguinal adenopathy, no systemic symptoms. How are you going to treat him? Vote now. Low dose ceftriaxone IM, higher dose ceftriaxone IM, ceftriaxone combined with azithromycin, or straightforward azithromycin at 1 gram PO. How would you want to treat him? Would you want to give him more drug as a shot or as an oral drug? All right, most of you are shooting from the hip and you're going to give him dual therapy, probably with the idea in mind that this is urethritis and you don't know yet what the cause of his urethritis is. So you're going to cover broadly right at the point where he needs care. He's already symptomatic. You want to interrupt the chain of transmission, ceftriaxone 250 and azithromycin 1 gram, and you would be correct. I'm going to change the story a little bit. What if he weren't so symptomatic and you did this as a screen, okay, and it came back just as gonorrhea? Unusual. It's unusual. Only 10% of male urethral cases that we know of with the type of circulating strains of Neisseria gonorrhea these days, are they asymptomatic enough at the urethra that the guy is walking around with it, could transmit it. Still, only 10% of them are asymptomatic. 90% do really cause that pus, okay? But if you knew that he only had gonorrhea and you had eliminated chlamydia from the equation, could you be a little bit more narrow with your drug use here? Or could you choose a whole nother drug that's an oral option like ciprofloxacin or cefixime or cefpodoxime. And this is not a question of what the recommendation is. This is a question of what you do in practice. What do you actually do in practice? So what's your answer? All right, let's see what the audience votes. Okay, so most people are still giving 250 of ceftriaxone, and a few people are also giving ceftriaxone 125 still, but virtually no one is actually usually using a quinolone or using cefixime 400 milligram tablet. That tablet formulation is actually back out on the market as of April of 2008, or cefpodoxime 400 milligrams PO. Okay, there wasn't really a right answer to that one, but let me tell you what the recommendations are, okay? Because that one was just, what's your practice? The recommendation is now officially, go with ceftriaxone if you have ceftriaxone, or if ceftriaxone is really unavailable, then you can go with cefixime. But you need to co-treat with azithromycin 1 gram PO or doxycycline 100 milligrams PO BID for 7 days, regardless of whether or not you've eliminated chlamydia or not. And the reason is because of the concerns that I'm going to delineate on the next few slides related to evolving gonococcal resistance. This is going to happen, and this is likely going to happen in the next decade of our life. Let's go back to the fact, though, that the gonorrhea treatment guidelines actually also highlight one very particular fact. If you're pretty sure that the infection is solely at the urogenital site, yeah, you can go with ceftriaxone or cefixime. But you know what? If you have a sneaking suspicion or very high suspicion that the pharynx might be involved too, and there it's the flip side, gonorrhea hanging out in the tonsillar crypts, probably asymptomatic 90% of the time. Only 10% of the time do you get that glaring exudative pharyngitis that you might even see just like group A strep. Okay, definitely asymptomatic carriers running around. You really need to treat those patients with the possibility of oropharyngeal infection with ceftriaxone 250. Cefixime, not enough drug to get really deeply into the tonsillar crypts, to be running around in the serum for long enough. The efficacy points really do drop for that site. Okay, and here are some of the data that have yet to be published still. Chris Hall is still working on the manuscript, but they presented it at a series of meetings, and what I've done here on this slide is summarized a bunch of things, and these slides will be available after the talk, just not beforehand, because then it ruins the fun of the quiz questions. So efficacy data for agents with activity against GC, let me walk you through it. Ceftriaxone 125, cefixime 400, cefpodoxime 200 versus 400 were actually tested in trials, and cefuroxime 1 gram PO. Now, granted, these trials are not very big. I mean, you just don't, in some places in the nation, particularly New England, we don't have a lot of gonococcal disease, and thank goodness for that. But they looked at the site. SS is just the urogenital or rectal. PH includes pharyngeal, okay? And what you see is for every drug at every dose, pharyngeal infection is probably consistently, the cure rate is lower for every drug, okay? Except for maybe arguably, well, it's still efficacious 94% of the time for ceftriaxone at 125. And they haven't even completed all the studies for 250, but we hope it would be better for that. Okay, and that's the same holds true for cefpodoxime and other drugs, but every time you talk about the pharynx, it's just harder to get rid of the bug from that particular area with the same dose of drug. So the concept here is that the CDC has promulgated a series of recommendations that dual therapy may hinder the development of antimicrobial resistance. The thing we were doing all along for our presumptive urethritis cases actually might have been driving the fact that we have yet to see extreme gonococcal resistance against third-generation parenteral cephalosporins like ceftriaxone, which if you think about it, at the 250 milligram dose is a lot smaller than what you could even give for a rule-out sepsis case, right? So 250 milligrams, arguably, we could still go up from there, and we may see that in the coming years, actually. Dual oral therapy may be more efficacious for pharyngeal GC treatment, but the data are yet to come in, so CDC was unwilling in this very evidence-based series of guidelines to say anything about the combination of cefixime and azithromycin orally. And what we do know to be the case is that we have very limited options in cephalosporin allergic patients. But this really has to be your cephalosporin allergic patient, not your pen allergic patient, but your cephalosporin allergic patient. Because the rates of cross-reactivity between third-generation cephalosporins and penicillin are less than 1 in 20. Less than 1 in 20, and probably even less than that. And there are details within the STD treatment guidelines to tell you that you as clinicians, when you use a parenteral third-generation cephalosporin, are practicing in recommended guidelines. Now, that having been said, if you're in a private practice setting and you have some risk of anaphylaxis, nobody really wants to own that burden. But you have options. But let it definitely be said that the CDC has laid it out very clearly that this at least is a recommendation to back you up, that the parenteral was really the way to go. The other parenteral medications that maybe would work would be a drug like spectinomycin. And it's a little scary, but that drug isn't even on the market anymore in the United States. And forget about desensitization. CDC was crazy when they recommended that. It just isn't very efficient to recommend it for a lot of people who are, more and more gonorrhea is actually being diagnosed in the private setting. Azithromycin remains in your back pocket, but it's in the tiny details of the gonococcal section. It requires 2 grams to actually effectively treat gonorrhea. And we do have 2 MMWRs, of course, from the western part of the nation, California and Hawaii, usually being the first to see the signals in gonococcal resistance, okay? And they definitely have already seen signals of high-grade azithromycin resistance. And treatment failures have already been seen even to 2 grams, which, as you all know, have you given 2 grams to your patients before in an effort to treat them? They tend to throw it up more too. It's not very well tolerated. So let me give you a little bit of history as a reminder. And the key point here is we just don't want to relive this. So this is what we have done in the past with gonorrhea. Well, in the 30s, it was actually even sensitive to things that weren't even arguably things that were antibiotics, but were more like potassium, permanganate, silver salts, mercurochrome. In the 40s, we finally got to penicillin. In the 44, 35% treatment failure with sulfonamides, which started in the 30s, so only a decade later. And 72, the penicillin regimen increased to 4.8 million units plus probenecid, but that was because it was in response to the fact that a few decades before, although penicillin therapy had started, it was started at a lower dose, and the lower dose was no longer working. By the 70s, 80s, we're talking about tetracycline resistance being reported. By the late 80s, penicillin's taken off the books, and 2000s, concern regarding rising quinolone problems, which we don't tend to use as much in pediatric medicine because still almost no quinolones are available for use in under 18, at least on the FDA books. So if you want to be official about it, we're not really supposed to be using it with those patients. And where are we now? In the last 2 decades already, there have been many reports from Japan and Hong Kong, so it always starts in Asia, and there have been many reports of resistance to 2nd-generation cephalosporins, then 3rd-generation oral cephalosporins, and now an isolate from Japan that was reported earlier this summer that was resistant to ceftriaxone. So we know that it's probably within the next decade that we're going to see something that's resistant to everything that's currently licensed on the market. So what's happening now is CDC sponsoring a series of trials on dual therapy, going back to older drugs in combination with the newer ones like gentamicin as an IM shot. I can't even imagine how painful that must be, combined with things like ceftriaxone. And we will see the data soon enough. So if you're ever faced with a case that you think might be failing treatment in front of you, you might be the first one. Hopefully you won't be the first one in New England to find this. It would be rare. It was probably going to be, first signal is going to be in California or Hawaii. But if you do, call your local Department of Public Health. Try to get a culture. Not that easy to do necessarily. Try to get susceptibility testing done and report to CDC for additional help, really more than anything else, immediate real-time help. You can use gonococcal gnats, by the way, probably within 1 to 2 weeks of diagnosis from a nucleic acid amplification test, the kind of DNA test that most of us are using to diagnose or screen for gonorrhea at this point in our careers, like the Aptima TMA or the Becton Dickinson GenProbe. All of those are nucleic acid amplification tests. So a la CSI, you could use these as rapidly as 1 to 2 weeks, by the way. We think 1 to 2 weeks after. Clearance of gonorrhea is faster than clearance of chlamydia DNA, okay? So you heard it here. The study has yet to be published, but the CDC is already espousing this notion, okay? So you could use those for test of cure. They're not recommending it yet, only if you have a suspicion. And I don't know if we're going to be going back to this, but I sure do wonder if the resources and the thought behind, do I have a lab that I could send a gonococcal culture to? If I wanted to, should I actually ask the lab, could they receive something sent in a culturette tube? Would that work to grow gonorrhea? Those are reasonable questions to ask your lab if you're ever faced with this question of, is it resistance to something that you just gave? Okay, so before we go on to the next case, questions about gonococcal treatment, because that was really quite a change in the 2010 treatment guidelines, that you really should be doing dual therapy for everybody for a lot of good reasons. I'll tell you there's some controversy about it. There are some experts in the field who did not feel that that had enough evidence to support. So not everyone's doing it, and certainly departments of public health, I don't believe, are calling clinicians just to remind them not to do that if they only use 250 milligrams of ceftriaxone for just a straight GC case. No question. Okay, we're going to move on to screening. All right, 16-year-old runaway female brought in by DSS for medical clearance prior to foster care. She is asymptomatic, but she reports oral, vaginal, and anal sex with multiple males in exchange for a place to stay. So you're going to offer the following gonorrhea and chlamydia screening: a urine nat, a urine plus a urine nat plus a rectal pharyngeal culture for GC and chlamydia, or a urine nat plus rectal pharyngeal nat, that DNA test or that RNA test. Genital swab nat, any part, just a genital swab, a general genital swab, plus rectal pharyngeal nat, or you're going to look up the 2010 STI treatment guidelines for guidance. I gave you an out. Vote now. Okay, let's see what people say. Okay, you're going to use nucleic acid amplification testing, and it looks like the majority of the room wants to do just a general genital swab. Wow, the word is getting out. Excellent, excellent. But there's still some people who are doing a smattering of other things. You know what? Doing any screening whatsoever trumps not doing any screening. So that is all good, all good. Okay, despite the fact that all of you who know this and use this know that that's the cleaning swab, not the actual sample swab. It's a bad picture, sorry, haven't had a chance to revise that. Chlamydia and gonorrhea NAT testing is still not FDA cleared for rectal and pharyngeal specimens, but now it is the preferred testing method over culture because it is several percentage points better in terms of sensitivity and specificity. While it used to be measured against culture, it's not a very good gold standard if it doesn't detect as many infections. So specificity is actually very good now with the newest generation assays that amplify chlamydia and gonorrhea DNA and RNA. So CDC was unable to argue labs, the FDA, into approving it or getting any of the commercial manufacturers to do the studies for extragenital sites. So they went another way. They twisted the arms of some major national laboratories, as well as the fact that they twisted the arms of all the public health laboratories that they already had connections with. And they ran validation panels, and many public health laboratories across the nation will do samples for you, or nationally, every clinician in their back pocket can force their lab to send their sample to Quest or LabCorp. I own no stock. I have no commercial disclosures. Those are the two major national ones that we know about, and the list is growing longer every day, that have run a validation panel to clear this testing for use for clinical results, okay? So other tests are being verified by other laboratories, and the concept we're moving toward, and the MMWR that I hope is stuck in queue, will be published in the next few months, will be that the idea is that the self-collected vaginal swab may in fact be slightly more sensitive than any other female sample, even urine, even the clinician-collected endocervical swab. The self-collected vaginal swab might be better. Any speculation onto why? Any guesses? They run studies, and they're always consistently a couple percentage points better. Yeah?
It's just a couple of percentage points better, though, right?
Yeah, just a few. So any screening beats no screening, absolutely. And urine, as a very convenient specimen, relatively less invasive specimen, still a very good specimen to get, always in the 90%. Those of us in the field have been speculating that women in the bathrooms collecting their own samples are spending great quality time with their vaginas, twirling the swab like it always was supposed to be twirled. If you read the package inserts on all of these, you as the clinician are supposed to have contact time with that area for a good 10 seconds, 15 seconds when you go to do it. But all of us as clinicians have been trained from clinician babyhood to make the patient comfortable, to minimize the time in stirrups, to do all of this. And I think we carry with that the idea that just touching it is good enough? Probably not. Look at the package inserts. Definitely look at the number of seconds that the manufacturer says that it should be in contact with the tissues to do this correctly. Okay, so that's coming. Self-collected vaginal swab. You heard it here first, maybe not. But, and also the idea that you can get rectal and pharyngeal screening for your high-risk patients, okay? And I mentioned some of these here. I want to point out one other thing related to repeat testing and repeat screening for high-risk individuals who have already demonstrated their high riskiness by the fact that they've carried the infection before. They are by definition in a sexual network that had that particular disease. So they are very high risk for reacquisition within the next 3-month time horizon, particularly for gonorrhea and chlamydia. So there is a standing recommendation from the CDC to repeat screening 3 months later. It's not test of cure, it's repeat screening. And by then, the dead DNA should be gone, okay? So that repeat nucleic acid amplification test for chlamydia is certainly gonna work at 3 months, definitely for gonorrhea. Is that clear? Getting a lot of nods. Yes, Susan Gray.
So I'm just thinking about some of my at-risk, high-risk patients having oral sex.
Mm-hmm.
Do you think that I should do an oral swab once a year for them?
I kind of picked the DSS case as most high risk because she was doing commercial sex work. What it amounted to is commercial sex work. The guidelines are actually not clearly saying that all adolescents need to be screened in the oropharyngeal region. Why? Couple reasons. Probably the most common organism floating around there, out of chlamydia and gonorrhea, which is going to be, it's going to be chlamydia. Everybody who's ever done studies on the oropharynx, even with the newer generation of chlamydia testing, the newest generation of chlamydia testing, can't find it. Don't find it more than 1 percentage point of the time, okay? And moreover, it doesn't hang out there as long as gonorrhea does. Gonorrhea kind of finds its happy home in the tonsillar crypts. Chlamydia doesn't seem to do that, doesn't seem to be as transmissible. So current guidelines, even from the CDC, say very clearly, don't screen anybody for chlamydia, but you can screen the high-risk individuals for gonorrhea. And gonorrhea, of course, prevalence points, way fewer prevalence points than compared to chlamydia. So in many populations, it's not worthwhile, it's not considered worthwhile to routinely screen for gonorrhea in the oropharynx. Okay. Let's talk about women and the rectum related to gonorrhea and chlamydia. Do they have to report a history of anal sex, or will it be sufficient to do a genital swab, like a vaginal swab? Will you capture the majority of transmissible infections for gonorrhea and chlamydia? For women, it's argued, yes, you will. For men who have sex with men, it's clear the answer is no, you don't. Very clear. You'll miss over half of the transmissible infections if you don't swab the anus on the report of recipient anal sex, okay? But for women, I think it's definitely clear that one genital swab, probably the vaginal swab, will be reasonable and the best screen. Although CDC is not saying don't use urine. They're just saying the best screen, the best screen. Doesn't take options off the table, just gives you more confusing options. Yes, Atsuko was next, and then I'll go to Katie. Yes, whose name I just blanked on. Okay.
If someone's still working in the ER, there have been patients who come in and said, I just had unprotected, the BU student who drank too much last night just had unprotected psych yesterday, wants to be screened for everything today. If they were exposed to GC or chlamydia, will that show on the screening test just 24 hours later?
Not necessarily. We think it'll show relatively quickly, and sometimes if you have enough contact time and whatever, well, it'll show in 2 different ways, Atsuko. It's possible that they're carrying their partner's material still, and it's not actually true infection in that case. Regardless, that individual has just essentially described a higher risk situation for acquisition and transmission of STIs. And arguably, what you should do in that situation is that person deserves screening anyway. That person deserves screening even if it was only a prevalent infection from previous to that day. So you can't be sure. You get them when you can. We are a very convenience-oriented service, those of us who are in adolescent medicine. So I would argue, go right ahead and do it. But explain to the patient that may not be reflective of the day before, that if they really want to capture the day before, even if this test is negative, coming in approximately a week to 2 weeks after the event is a really good time to come in. And of course, all STIs are not created equal, right? So maybe chlamydia and gonorrhea you could detect within 1 or 2 weeks with these super sensitive NAT tests. But what about HIV? What's the window period swallowed down to? What about syphilis, which is much lower risk, much lower prevalence, except in young men who have sex with men? What about trichomonas? It would take a little longer to develop symptoms, certainly within a week or so. Maybe hard to detect if you're not symptomatic. We don't usually screen for it still. Okay.
I remember doing a child protection team rotation during residency and being told that for cases of possible abuse that you wanted to get a culture as a gold standard. Is that still true, even though these tests seem to be better than culture?
Mm-hmm, mm-hmm. Great question. There are actually sections of the guidelines that address sexual assault and the usage of all different types of laboratory tests, STD tests in particular, for sexual assault. That is based here, what's governing what we do as clinicians is at least in part what is acceptable within a court of law to be something that a case cannot be challenged on. Okay. So in many courts of law, they're finally moving forward. And what they're doing in child protection is they're wanting to confirm that one positive with another positive that's a different test. So it's simply a different amplified portion of the genome to make doubly certain that whatever chlamydia trachomatis they found was actually chlamydia trachomatis of the sexual variants that are screened for in the nucleic acid amplification tests. And there wasn't cross-reactivity to, God forbid, something else. Okay. For gonorrhea, the cross-reactivity, dependent on the test, can happen. So if you amplify it in 2 different platforms, some courts of law will now accept that. But it matters very much what your local practice is, and consulting with Alice over at Children's and my colleagues like Bob Segi and his team over at BMC, probably worthwhile to see whether or not courts of law are starting to accept it in Massachusetts. Okay. Culture still remains a gold standard because of the specificity related to it. If you grow it out on a plate and you know darn sure it's Neisseria gonorrhea, not Neisseria meningitidis, not Neisseria sicca, lactamica, or anything other, yeah. So that's what you're running into here, and I would talk to the colleagues specific in that area. But it's definitely shifting. That's the good news. It's definitely shifting. Carolyn Black published a paper about the specificity in those child sexual abuse settings. It's a good recent paper, only about 2 years old. Okay. We're going to move on to what amounts to EPT, right? So, not really a question about EPT yet. I'm curious to know, you in the audience, before today, what was the most common method you would use to treat partners of chlamydia-infected patients? Would you encourage the patient to bring their partners in with them when they return for treatment? Would you, and you can only pick one, sorry, there's no way to pick both. Give the patient extra medication to give to their partners, give the patient a prescription for their partners, regardless of what you knew about the legal landscape. Counsel the patient about the need to self-refer partners, call the health department because it's their job. None of the above, because it's definitely a health department job. So let's see what the audience thinks. What had you been doing? What had you been doing?
There's also the postcards.
The postcards. Or going on to a website. The website that's like, yes. Inspot.org. Inspot.org, I think. It's started by San Francisco. I should have put that up there. Ah, well. Okay. Well, it looks like about half of the population in here, about half of 20 people, are saying that they usually counsel the patient about the need to self-refer their partners for treatment. Great. At least you're doing that, right? Because sometimes we're only human. I mean, unless you're an automated robot, you probably don't do the exact same thing every time you have a chlamydia patient in front of you. Hopefully, the majority of us, the majority of the time, are remembering that the index patient will get reinfected unless we get their partners in for treatment somehow. So regardless of how you do it, this is great. Thinking about it is the key. It is the most common reported STI in the United States, and I think those of us in the field of public health are perpetually shocked by the volume of cases we've now been discovering that are completely asymptomatic, and we don't actually know the meaning of that. We don't know how many of those asymptomatic women are truly progressing on to PID if we don't capture them, okay? That is one of the great unknowns, surprisingly. But we're still going to do it. In the absence of newer evidence, we need to screen, and when we find it, we need to treat as clinicians, not as public health people. That's a different concept. The number of cases in Massachusetts alone, mushroomed, doubled in 10 years. And this is definitely a testimony to more clinicians getting savvy to testing and screening, as well as better generation assays that detect it better. And patients with chlamydia infection are at increased risk for reinfection if their sex partners are not also treated. So what is this idea of EPT, expedited partner therapy? Well, it makes sense that for that patient, if you give them more drug for their partners, or you give them a script for drug for their partners, or you tell them that they go to a specific pharmacy for their partners, that's happened in Washington State, they do it pharmacy dispense stuff, it's going to be at least as good for reinfection, decreasing your risk for reinfection, as usual care, which could have been telling the patient to tell their partners about stuff. But CDC actually sponsored a study on this, and they proved it. It's sort of like, you know, hopping out of a plane. Do you really need the parachute to make sure that you survive? Well, yes, nobody's going to do a study, thankfully, of that. CDC's not sponsoring a study on that. Don't go away with thinking that. But they did sponsor studies on EPT, and the EPT trials were really interesting because basically the proportion reinfected, so the higher the bar is on this graph, the worse you're off, okay, was dropped better for expedited partner therapy, however you did it, best for gonorrhea. It wasn't statistically significant, although it was point estimate-wise different for chlamydia. And for the combination, it was driven by gonococcal disease. So what have we done in Massachusetts? We've done chlamydia disease. I'll explain, don't worry. But here's that website that I was talking about, okay? This is the cdc.gov/SCD/EPT. Don't worry about copying it. A, you can get it. B, you can Google it. CDC EPT. It's much faster to get to it, okay? And this is a screen capture of, couldn't be more than a week ago, they just updated this. And the date that they updated it is at the bottom of the page. Most of the nation has gone green, and this is entirely because CDC pushed EPT out as a legislative initiative state by state by state. Okay, New England's all green. But saying New England's green doesn't mean that you can do the same thing in Rhode Island that you should be doing in Massachusetts or you should be doing in New Hampshire. You have to read the dizzying details, and under each state, they summarize what happens with the details. And in Massachusetts, we elect to do chlamydia alone. Okay, EPT is supported by the CDC and permissible in at least 30 states. That was 37 at last count. Standard treatment for chlamydia infection is 1 oral dose of 1 gram. EPT is shown to be safe and effective and at least as good as usual care. Most states with long-standing EPT programs also have had no reports of adverse events. California, been doing this on the West Coast for over 5 years, close to a decade. No adverse events. They had a hotline never got used. So here's our clinical advisory in Massachusetts that Connecticut just borrowed, by the way, also. And we borrowed New York State's because we were not the first off the block here. And in August of 2011, we put it on our DPH website, my own systems website. It's not always that easy to Google my own State Department of Health website. So if any of you have any trouble finding this thing, here it is. It's the clinical provider notification. It went through a number of clinical provider emails, listservs, but we're not very great about getting in touch with docs and nurses who are actually prescribers. And connected to that very same document is the partner patient information brochure that should be going out, and this is what we'd like to happen in Massachusetts. And most states that have implemented EPT have requested that the provider who does it give a patient a very specific brochure. We didn't say you had to give the one that we have on the DPH website, by the way. You have to give it or its equivalent. It's in a Q&A format. It's been vetted 6 ways to Sunday for like a 6th grade reading level. And there's definite encouragement to follow up with clinicians, not to bypass clinical care completely, those partners, because really that's still the gold standard. And no state in the nation says, oh, you providers, you have to do EPT. No, it's always couched as if your patient's partners are not likely to come in for care or your patient is getting repeatedly infected, EPT would be a consideration and a recommendation from a Department of Public Health. Voluntary, not required, that's that point there. And in Massachusetts, we delineated 3 options we recommend, but we didn't take other things off the table. It could be up to the clinician's imagination. You can write a written prescription, or we have a pharmacy board of regulation carve-out that says that if you write EPT in the top line of a paper script, you don't have to write a name and you don't have to write a date of birth. Every other script, every other prescribed medication needs to have the 2 identifiers and even sometimes address, I think, in the Board of Registration in pharmacy saying that the prescription has to have it. EPT for chlamydia, carved out. If your electronic medical record system doesn't permit this, what very clever community health centers have just started doing is creating EPT the dummy patient, which is really interesting. we'll see if this works. We're going to try to replicate it in a couple of places and see if this actually works. Because then the patient still has to give it to the partner, and the partner still has to carry it to the pharmacy. And then at the pharmacy level, they still need a name and somebody to pay for it. So somebody still has to admit to be not anonymized at that point. And there's one other way you could do the written prescription or direct dispensation of the medication, a few extra doses for all the partners, as long as it always trots along with those brochures. I think there's a safety factor when you make somebody take a script saying EPT in the top line, although there are more barriers for the partners to get the drug, at least then the pharmacist can also offer counseling. And the way pharmacies are rolling out in Massachusetts is, in theory, that's yet another point where they can give this partner-delivered patient information, or they can give this information, this clinical, same frequently asked questions thing. Okay, any questions about that? Maybe I should answer the question about why just chlamydia. You want to know how this thing passed in Massachusetts? It passed as a budget rider on a budget that had to be passed. For 6 years, it never got out of conference committee. And then finally, Al DiMaria, the state epidemiologist, works with Kevin Cranston, who's now the director of the Bureau of Infectious Diseases, and we work with the legislators. And they basically tack it on to the August 2010 budget. It wasn't totally under the radar screen. Planned Parenthood was fully pulling in grassroots support for this. A lot of legislators got called on EPT for chlamydia. But somewhere between the Senate and the House, it lost the language that Al and I had written in there related to the fact that we wanted to make expedited partner therapy really for more than just sexually transmissible diseases, but for diseases dangerous to public's health, like Neisseria meningitidis or pertussis. I mean, how many of you as pediatricians have ever prescribed, sight unseen, tons of extra doses of azithromycin for a family of an index case that actually has pertussis? That in theory is not explicitly legal within the state that you did it in. It's unlikely to be explicitly legal. But we do it anyway. We do it in our patient's best interests. We do it in our family's best interests. So we have to be careful. You should be aware of what you're doing. But I'm just saying, we tried. If we can prove that it works for chlamydia, that it's safe for a few years, I think we'll be able to broaden the legislation and then bring it down to the regulatory level, because regulations are easier to change than laws. Regulations can be easier to change, and we'll change it later on down the line.
So I'm sure that that patient information packet probably says something about if you have known allergies to this medication or have any questions about your allergies, call us or something.
Absolutely. Do not take in very big, bold-faced letters. Absolutely. Is definitely one of the things that was framed. And again, we can't take the credit for it. 36 states went ahead of us on this endeavor. Okay, so we borrowed a lot from a lot of other states. We learned a lot from other states and how they implemented. Okay, any other questions about EPT? Okay, I think we still have some more time to talk a little bit about herpes. What do you think? All right, so let's switch gears. Case history. 18-year-old college student comes to you with the results of her herpes select. Focus, ELISA. HSV1 specific antibody not detected. HSV2 specific antibody detected with an index value of 2. The lab report states that anything above 1.1 is positive. She has never had any genital symptoms. She wants to know what to tell her husband, who as far as she knows does not have herpes. He has been her only lifetime sex partner. She has had no other history of STD. What is the next question you would want from her? What additional information would be helpful? Would it be helpful to know her race, ethnicity? Which lab she had the test done in? Whether she is telling the truth about her number of previous partners, or all of the above.
Wait, I'm confused about why did she have that test done?
It's an inherited thing. She may have gone in as a worried patient, asked for STD screening, and in whatever facility she was in, she was also offered herpes screening. Or she maybe heard about the scarlet letter disease herpes, and she got screened for herpes. But you're absolutely right. It's not recommended to screen for herpes in an asymptomatic individual, because what then do you do with that information? Great question. And that is exactly the point. But you've inherited this case. So what would be the next thing that you're stuck with? What would you want to know about her? Give me a sense. All right. Let's see what a little under 20 people would have done. Yes, that would be nice. The truth of the situation. It's always nice to have the truth. If to be the window or the fly on the wall in that patient's bedroom. Well, maybe not. Okay, her race ethnicity is actually really important. We do not live where STIs are concerned. It's not a colorblind world, at least not to STIs. So I'll get into that in a second. And here are the data to support some of the concepts here. And several of you in the room have seen me display this slide before, but I'll walk you through it again because I think the data are so valuable. It's from Fuji's Shu's article in JAMA that was published in 2006 based on NHANES data, arguably a good population prevalence sampling in the United States of America, National Health and Nutrition Examination Survey. And what we're doing is we're looking at lifetime number of sexual partners increasing across the x-axis here. And on the y-axis is the proportion of people with herpes 2 positivity in the bloodstream, seropositivity, okay? So for every set or strata of lifetime number of sexual partners, what you see is that men versus women, the men have less seropositivity than the women. But for every strata within the age groups, you see that non-white patients have higher rates of seropositivity even at the same number of reported levels of sexual partnerships previous to that. Speaking a lot to sexual networks, to sexual partnerships, to dyads, to relationships, to who you hang out with and who you have sex with, I think. And your risk, therefore, for acquisition and transmission having nothing to do with actual individual behavior. Something to think about. All right, herpes prevalence in terms of age group over time, just a reminder, no matter which years you look at with NHANES, in general, your patient population, by the time in the United States of America you reach the ripe old age of your 50s, you, the majority of the time, 80% of you are going to be herpes seropositive for herpes serotest 1, the one that we used to call the above the belt herpes, herpes 1, okay? Not always above the belt, but usually above the belt 60% of the time still. Herpes 2, it's a quarter of the American population. That's the way you should think of it. A quarter of the American population, by the time they reach their 3rd decade, has become herpes 2 positive. And only a tenth of those people, even less than a tenth of those people, ever show symptomatology from it. But they're shedding it and transmitting it, and there are disease outbreaks related to transmission from this. So there are arguments back in the field. So what's your advice? You've inherited this patient. You would never have done serotesting anyway because you knew the guidelines were not to do serotesting in an asymptomatic 18-year-old, but you've just gotten this result anyway. And so how are you going to interpret it for her? You're stuck holding the bag. False positive? She has herpes 2 and just never had a symptomatic outbreak. She's probably seroconverting, having acquired it from her current partner. Or actually, you're not sure. You can vote you're not sure. How are you going to counsel her? It's a tough case. All right, great. Let's take a look. All right, many of you are convinced at this point she has herpes 2 and just never had a symptomatic outbreak. And some of you are thinking, not sure, about a quarter of you are thinking she's seroconverting. Great thought given how low the actual number was. I don't know if you remember, it was 2 and the cutoff positivity was 1 or 1.1. Okay, so let me go back to this graph. Let's just say that we agree, for the sake of argument, she's white and she's only had 1 partnership. Her odds of carrying herpes 2 at the age of 18 are probably no greater, as a woman, at the age of 18, probably no greater than 10%, and arguably considerably lower given that she's had only 1 sexual partnership in her life, okay? So when you calculate the positive predictive value of this particular test, over half the time, this test is going to fail. It's wrong. You have to actually do the numbers and go back to the way we calculate statistics for sensitivity, specificity, given the prevalence of the population serotest positivity. But over half the time, in this particular case, with a white woman who has had only 1 sexual partnership, in theory, it's actually, odds are, it's a false positive. Very interesting numbers. You have to run the numbers to believe it. Yes?
What if your strong suspicion was that she'd had more than 1 sexual partner, she wasn't telling you the truth?
Mm-hmm. Even then, until you reach serotest prevalence on the order of greater than 5%, many times tests don't perform nearly as well as we as clinicians want them to perform. You really have to run the numbers, given that test, and given a guess, which we have. We have good guesses with NHANES data. You could take the population seroprevalence and give it a good guess and calculate the true positive predictive value of that positive test. But is it arguably, you know, that classic 2 by 2 diagram, test positive, test negative, disease positive, disease negative. Which box is she falling in? That's what you're thinking of here. And we as clinicians, we want to believe in these lab tests. We order them. We wouldn't do them on our patients unless we thought we had some belief. But it turns out that unless you reach higher percentage prevalence, it's very likely that some of these tests are not very good for true positive predictive value. And we're talking about tests that are actually very good. The herpes select in particular, 90% sensitivity and specificity, over 95%. And that's what I'm calculating positive predictive value off of, this type of sensitivity and specificity, over 95%. Still, run it on your 100,000 patients, and you'll see that over half the time for this particular patient, it's actually the wrong answer. Okay, if your patient is really wanting to know, there is one more thing. The Western blot, similar to the Western blot, the way the HIV tests are run, there is a Western blot assay now out that's commercially available. I shouldn't say commercially. It's Rhoda Ashley's lab out in the University of Washington. And you can actually have patients who can pay for this Western blot for confirmation or denial of whether or not this single test is actually the true test or the true answer. But I'm going to give you one more hint, okay? Although the package insert states that an index value of 1.1 should be interpreted as positive, several experts use a cutoff of 3.5. And the positive predictive value is as low as 38% in college students with very low HSV2 seroprevalence. If the seroprevalence was only about 3%, the positive predictive value was 38%, meaning 62% of the time the test was wrong. That's seriously food for thought. I think about it all the time in relation to other tests that we do as well, and how much test ordering we do. So the issue here is really herpes serologies have a lot of limitation. They don't tell you how long the patient is infected, if they had or will have symptoms ever in their lifetime, how likely a person is to shed asymptomatically. And more recent studies show that those people who are serotest positive never had an outbreak, never had a genital outbreak, clearly shedding. That's the latest study from over the summer that got published out of those herpes experts. Anna Wald is one of them, Larry Corey's another. They are clearly shedding, even if they've never had it before. That's why there's so much transmission, and that's why 25% of the population is likely positive, indicating that they've mounted some sort of immune defense. It's merely a marker of exposure, not a marker of disease. False positives, we've talked about, and false negatives can also occur with these tests because it takes so long for antibodies to develop. Remember, again, antibodies take 6 weeks, sometimes maybe as short as 4 weeks to develop following a primary infection with herpes, and this we always knew. So the testing issues are legion, but what's coming down the pike is something even more confusing. The fact that there will be a genital ulcer PCR, there is one. It's just that most of us don't know where to find it right now. Becton Dickinson does have a genital ulcer PCR. Did I get that right? Yeah, Becton Dickinson's assay is amplifying for herpes DNA, specifically as a nucleic acid amplification test. But the test is now licensed, the news came out this summer, for genital ulcer disease, active genital ulcer disease. It's not licensed for shedders, okay, or asymptomatic individuals. Just a reminder, other tests that might be useful, and these are other tests. People think about IgM. IgM doesn't really work very well for herpes. It turns out people will remount an IgM defense even if it's upon reactivation disease. So IgM doesn't tell you about recency of disease. The way we learned in medical school or nursing school that IgM was usually the first marker, only got mounted once in a disease lifetime. No, it's much more complicated than that. IgM can actually be mounted upon reactivation of infection. So the IgM-specific assays are not specific, first of all, nor should they be used for this purpose. Okay, so when could you use serology, though? Patients presenting for an STD evaluation, especially if multiple partners HIV infected and MSM at risk for HIV, because HSV and HIV tied, associated transmission acquisition issues, different issue, okay? But it's not recommended for routine prenatal or universal screening. And the arguments for HSV2 serology screening, though, are that the experts in the field who are really pushing this idea are that you could self-identify and potentially cut down on transmission. You could self-identify, cut down on transmission, and they may be motivated to protect partners from what amounts to a lot of asymptomatic disease much of the time, but can be very, very stigmatizing and harmful in those individuals who do actually have genital ulcer disease from herpes. Okay, and those are the arguments against. Unproven benefit, effect on sexual risk behavior is not perfectly known, potential significant costs, increased demand on the healthcare system, unnecessary C-sections if a woman is labeled herpes positive. What does that mean the next time that she goes to, if the first time that she ever goes to deliver? I want to highlight one new treatment issue from the 2010 treatment guidelines, and that is the addition of famciclovir, 500 milligrams PO times 1, then 250 milligrams BID for 2 days as a new regimen for recurrent HSV. Nothing else changed in the treatment for HSV. Does this arguably affect any of us who do adolescent and young adult care? Yes, if young adult. Famciclovir is licensed for use in those 18 or older. 18 or older, okay? So it's another short course on the long list of short courses that you could use to treat recurrent infection. And the short courses are so short at this point that some of them are even only 1 day's worth of therapy. So I'm not sure why you would choose to do this one particularly, given that recurrent therapy, famciclovir, that's that new one, or 1 gram POBID for 1 day. You could use that. Acyclovir remains the PD one of choice. Valacyclovir is actually licensed for use for genital herpes in those who are of pubertal age and up. Interesting FDA approval. And the first clinical episode treatment, okay, this is all in the STD treatment guidelines, which you can download easily, hasn't changed at all. Tends to be a little bit longer treatment or until clinical resolution. 7 to 10 days or until clinical resolution. Don't forget, this is not new news in 2010, but in 2006, they amplified the news about daily suppressive herpes therapy for people who have recurrent genital ulcers. Those the few people in the population who do have recurrent, consistently recurrent infections. There are a number of safe regimens known up to at least a year for use, and should discuss the need annually to continue therapy with patients. Now, I'm just going to do one last moment on herpes here and pause to laugh at the CDC STD treatment guidelines, which I did mention to you earlier, also give clinicians a whole host of counseling messages that they might do with their patients in the 15 minutes that they have with them in the office. Okay, so you are supposed to discuss the natural history. The first episode, encourage partner notification, abstain from sex when lesions or prodrome are present. Condoms reduce the risk of transmission. Transmission can occur when asymptomatic. And the risk of neonatal infection, which is new in the 2010 guidelines, should be discussed with men and women. And you should counsel pregnant women not known to be affected with either HSV 1 or 2 to avoid genital exposure. Asymptomatic persons, what do you do with their diagnosis? This is what you can do. HSV 2, it goes on. And I got to tell you, that I had a long conversation with one of the great nurse practitioners that I happen to work with, Allison Marshall. She works over at the South Boston Community Health Center and set up their adolescent practice, I think, over there with a whole bunch of other people. And she pulled this really great study. A study from 2004 showed that patients were satisfied with their care if they had at least 15 minutes FaceTime with their practitioner. So you don't need to spend hours counseling them on every point that the CDC suggests that you counsel on. But the key is probably bringing them back for that follow-up visit to clarify a few key points and say to the patient, so what did you hear? The day that I gave you your herpes diagnosis, what did you really hear out of the things I tried to tell you? What is your impression? What are your questions now in follow-up? Because much of the initial information we try to give them, we dose them up with, we inoculate them, they're not hearing. 48 hours after the visit, gone. And her suggestion, she came up with this really nice mnemonic, the 4 T's just for the initial visit, 4 T's, transmission, treatment, maybe mentioning it to your partner, maybe not, and you as the clinician really being a therapist with your patient to really understand what does this disease mean for this patient, okay? That could be different for every patient. Okay, yes, go.
What about with adolescents where they might be kind of changing their sexual partners maybe more often than other age groups? Do you offer the daily suppressive therapy in hopes of kind of decreasing disease transmission even if they're not having frequent genital outbreaks?
No. The short answer is probably no. I do it based on the people who are having frequent outbreaks. I maybe don't personally wait for 6. I wait until I see them on a track because patients who present one way tend to present that way over and over. And I will have a conversation with my patients about when to start suppressive therapy, if it's the right choice for them. It's not mandated. But definitely it's that back and forth relationship with a patient that will clue you into whether or not it's worthwhile. basically, at this point, sit atop the knowledge that a lot of herpes transmission happens, but that's why we have immune systems also. It's not entirely the clinician's burden to stop every herpes transmission event. Okay, I think in the interest of time, is it 2:40? Are we gonna have to stop? It is this 2:40. Okay, let me see what possible messages. I think we can skip the trick one. I think most of you know what to do with that. The only comment I would have had was just the fact that if you think you have treatment failure, 3 to 5% of the time, trick can be resistant to metronidazole, and there's a phone number in the STD treatment guidelines that you can call down in Georgia. They will send you media. They want your protozoan parasites, okay? They want to study those protozoan parasites. So if you think you have resistant trick, goodness, call the DPH or call the number in the Atlanta number, and you'll get the parasite lab at CDC. It's not the STD lab. Eventually you'll get a hold of them. You'll get some media, and you'll be able to send it down for testing. In the meantime, the treatment guidelines do tell you about how to handle your patient with that may have been resistant to that 2 grams of trichomonas, or may have just had reacquisition or reinfection, okay? Either way, what's your next step? Do you treat with twice-a-day metronidazole? That's what I just did with a patient. That's one of the options. Do you move to Tindamax, tinidazole, which is quite expensive, hard to get, prior approval required? Could justify it. You have options. They're all listed in the STD treatment guidelines. So let me leave you on that note. Some resources that you can have here. There are STD resources at the Department of Public Health, all departments of public health. There are treatment guidelines. That having been said, I still want to drive all of you in this room more and more to the web, because the web is the living document. So as gonorrhea resistance raises higher on our screen, as changes come, the CDC is staying quite accurate on updating the website, even if they're not very good at publishing MMWRs very rapidly. They are very good at updating treatment recommendations right on that website, and the website is actually very easy to navigate for treatment guidelines related to STDs. And the last resource is my own organization. We are one of those 8 clinically funded organizations to do the National Network of Prevention Training Centers, to keep clinicians up to date. So if you have colleagues in other parts of the nation that haven't heard about us yet, come to one of our courses. You'll be sold. I swear to you, you'll be sold. And they're all around the nation, and they're also in web form. So go to our website too for much more than you would ever want to know about HPV, syphilis, chlamydia, herpes, HIV, gonorrhea. I'll stick around for questions. Thanks so much for your attention.